Order, order. Good morning, all. Thank you for coming. It is my great pleasure to introduce to you Kate Smith and Jaimie Pechan, co-founders of the Community Heart Failure Program. All right. So Kate Smith, Jaimie Pechan, founders of the Community Heart Failure Program. Kate is a Harborview veteran, if I may say that. Been here for 25 years, 15 in the section of cardiology. Jaimie is a doctorally prepared nurse practitioner, worked at Harborview and University of Washington for 10 years. Uh, to say that these two are the most compassionate, conscientious, and driven people I know would be an understatement. A lot of people, a lot of people have ideas and pipe dreams of, helping the less fortunate, helping, poor, making a difference. But it takes a very special breed of person to take those ideas and dreams and actually make it a reality and follow through on that. Jaimie and Kate are that breed. Of their own conviction on and resolve, they started the Community Heart Failure Program at Harborview in October 2021. It has since transitioned to a full-time program since October 23 and has expanded from a two-person operation now into a multidisciplinary team, including pharmacy, care coordination, cardiologists, etc. And we are in the process of adding more staff and growing further. So that's very exciting. Um, in the process, the Community Heart Failure Program has received acclaim from the UW community and from outside in the form of significant philanthropic donations, media attention, etc. And as some of you may know, we were recently awarded the Heart Failure Society of America's Outstanding Heart Failure Care Team Award for the year. So hopefully, this is a harbinger of great things to come. That being said, please join me in welcoming Kate Smith and Jaimie Pechan to the dais to tell us a little bit about their work and about their journey. Thank you.
Hi, thank you so much for being here today. I'm Jaimie.
And I'm Kate.
And this is our grand rounds about the Community Heart Failure Program called Lessons from the Invisible City. If I can, there we go. Neither of us have any disclosures. I'd like to start this presentation with a quote from Italo Calvino and his book, The Invisible Cities. For those who pass it without entering, the city is one thing. It is another for those who are trapped by it and never leave. I like this quote because it illustrates a reality that we see often in our work. There are two cities here in the greater Seattle area, the one that we all live and work in, and the other one that's both everywhere and invisible to all at once. You might notice it when you walk past a homeless encampment. Oh, better? No, better. Is it better now? No,
I don't know if you want to step or
step back. I think that made it worse.
well, then step forward. Yeah.
Step forward.
The mic. I say we just as long as it isn't.
Is this a concept for online?
It's for you.
Oh.
Okay, great. If it doesn't bother you, we'll just keep going.
Really wanted to sing.
Okay, so you might notice what? Okay. Does this work? Yeah. Great. Yay. Thank you, Mernal. Okay. So I'm going to start the slide over again. I'm going to start with a quote by Italo Calvino from his book, The Invisible Cities. For those who pass it without entering, the city is one thing. It's another for those who are trapped by it and never leave. I like this quote because I think it illustrates a reality that we often see in our work. There are two cities here in the greater Seattle area, the one that we all live and work in, and another one that's both all around us and invisible all at once. You may notice it when you walk past a homeless encampment or a group of people, some getting high and some ranting incoherently on the street. You could see it in the broken down areas of the city that you rarely need to drive through, or outside beaten up motels that line Highway 99. The Community Heart Failure Program was built to be a bridge between these cities, to bring healthcare to people for whom barriers to care often seem insurmountable, and help those of us who live here in this city to better reach and care for patients in these circumstances. We will show you a lot of pictures of the environment we see our patients in and various situations we find ourselves in. This is not meant to sensationalize the lives that our patients live, but instead to show you their reality. And we ask that you consider the lessons that we've learned from our patients today with an open mind.
So let's start with introducing ourselves. Jaimie and Kate, those are us two. And then we have a part-time pharmacist, Alex Deng, a part-time PSS, Soli Halleck. We also have Dr. Hidano and Dr. Yadava with us in the field once a week. In addition, Dr. Yadava has helped us with research and has helped build out our point-of-care echo program. So for those of you who may not know exactly what we do or have not kept up with our evolution, let me describe what our program looks like today in the next few slides. First of all, we're accepting patients with HFrEF, patients who've not been making their outpatient appointments and who are often being readmitted to the hospital, and patients must have at least one of these: a severe substance use disorder, mental illness, or be homeless or chronically homeless. We're out in the field seeing patients 5 days a week. We see 6 to 7 patients a day, and we go out in pairs, a provider with either a nurse or a pharmacist. We can see patients a couple times a week if they're unstable, and if a patient is stable, we might not see them but every other month. Typically, though, we see patients every 2 weeks to every month, and our current panel is about 90 patients. We get 2 to 5 referrals a week. So what does our typical visit look like? To begin, we conduct visits where a patient prefers to be seen. Just this week, we've seen patients at shelters, permanent supportive housing apartments, in a car, at tiny villages. And our visits can be very simple when we first meet a patient. After time, we do anything a provider can do in the clinic and often much more. We draw labs in the field, we have a cardiac POCUS, and a new on-the-market 12-lead EKG.
One of the areas we really focus on is medication management. I think you can see a picture of me up there in that top corner. That is with a haul of medications that I found in a patient's backpack that I was trying to go through. And the spot next to it is a typical room where I might try to find those medications. We were there the other week trying to find his Mediset. And that kind of a hoard is typical for someone with a methamphetamine use disorder.
Another big part of our visit is care coordination. People often ask us, how do we connect with patients who don't have a phone or who sleep in different areas every night? And the answer is complex care coordination. We use connections with the community we've made with case managers, building staff, and other community providers. We also use a harm reduction and trauma-informed care approach during our visits, which we'll explore more in our talk. And finally, some of the hardest work we do is goals of care conversations. Our patients can be at the end of their life, and they often don't qualify for advanced therapies. So we start with goals of care conversations and planning. We help inpatient teams navigate patients if they're ready for comfort care or hospice. And in fact, we just spent an afternoon with our cardiology colleagues up at Northwest, helping transition a patient to comfort care, and we were able to stay with him until the end of his life. We now have a U-Car. So we have a service area that's quite large. We go up to the border of Shoreline and down to Renton and SeaTac. We do cluster our care. So some, like in the morning, we might be north, and then in the afternoon, we might be in the downtown corridor.
So that's just a little bit about what we are and who we do. Of course, a program like this doesn't just spring into existence fully formed. So we wanted to take a little bit of time to explain how and why we chose this condition in this population, and then discuss our program's creation and growth. So why heart failure? It's common. 6.7 million American adults in 2020 had heart failure, and that is projected to rise to 8.7 million Americans by 2030. Mortality and rates have increased since 2012, and approximately 1 in 4 individuals will develop heart failure in their lifetime. It's also extremely expensive, both to society, to patients, and to our healthcare system. Direct medical costs for heart failure alone were $32 billion in 2020 and is projected to rise astronomically in the next 10 to 20 years. And the majority of these costs are hospitalizations. It's also highly treatable. We have excellent guideline-directed medical therapies, and we know that guideline-directed therapies can decrease the risk of heart failure, hospitalization, and death by more than 60% and extends event-free life expectancy by an average of 6 years. Which brings me to my next issue. Oops, too far. Which is that heart failure is inequitably treated. 1 in 4 patients with heart failure are receiving quadruple guideline-directed medical therapy. And equity in heart failure care is a known issue being highlighted by many national organizations. This is part of a statement from the American Heart Association that they released in 2024 about inequity in heart failure care. And I just want to read this top section to you. It says, inequitable treatment is related to a confluence of social determinants of health, healthcare professional bias, and structural racism, combined with clinical inertia and clinical uncertainty. And for me, at least, that's a pretty hard look in the mirror. It's saying that the way that we are providing care isn't reaching the people who need it the most. The Heart Failure Society of America also noted in their 2025 epidemiology and outcome statistic updates that Black, American Indian, and Alaskan Native individuals have the highest all-cause age-adjusted heart failure mortality rates compared with all other racial and ethnic groups. And from 2010 to 2020, heart failure mortality rates increased for Black individuals at a rate higher than any other racial or ethnic group.
So we think it's important just to remember what we mean when we speak about social determinants of health. Social determinants of health are the conditions of the environment where the individual exists. So examples are, for negative ones, poverty, lack of food, housing insecurity, incarceration, addiction, and all of these our patients face. Social determinants of health are important factors that weigh in on somebody's ability to access healthcare and especially manage something as complicated as heart failure.
Social determinants of health are also multifaceted and complicated and difficult to measure. So the CDC and the ATSDR developed the Social Vulnerability Index. This measures vulnerability across 16 census-based areas, grouped into 4 themes: socioeconomic status, household characteristics, minority status and language, and housing and transportation. What that looks like in action is something like this. So this is a map from the kingcounty.gov, and this is the condition of the Social Vulnerability Index condition for King County. So the condition is the overall ranking of the 4 social themes combined, where lower values indicate high vulnerability and high values indicate low vulnerability. So the lightest colors are the highest vulnerability, and the darkest colors are the lowest vulnerability. The red dots are areas that we see patients. You'll notice that there's some dots spread out across the south side, and then they stop because we can't go any further than SeaTac, but we know that there's a massive need in that white area down south. The line follows along up Rainier Avenue, where there's a lot of homeless encampments and permanent supportive housing. It clusters downtown, which is has a very high homeless population and vulnerable population. It's scattered throughout that lower vulnerability area, and then it picks up in a straight line right up again along Aurora 99, which is another area with a lot of shelters, homelessness, and low-income housing. The scattered sites are particularly interesting there. Those are primarily tiny homes. Tiny homes are temporary housing that's built for people that are chronically homeless on land that's going to be developed for market rate commercial or residential use. And for 1 to 2 years, they can build these small homes for people trying to transition to more permanent housing. They are small, they do not have running water, so they have like a communal kitchen and bathroom, and sometimes they don't have heat, and they are only there for 1 to 2 years. So within that context, we'd like to talk a little bit about the demographics of our program and some of the social determinants of health issues that our patients face. We have enrolled 158 people since the inception of our program. 55.1% are still with us. Of those that were discharged, about a little bit less than half died, and a good number were able to transition to clinic-based care, which we're pretty proud of. The average age for one of our patients is 54.9 years, which is much lower than the national average for a heart failure patient. And our patients skew predominantly male. We have primarily HFrEF patients. That's sort of a function of the fact that we've had to tighten our criteria to HFrEF only. But of our 133 HFrEF patients, LVEF on enrollment averaged 27.7%, and LVEDVI on enrollment averaged 120.2 milliliters per meter squared. So our patients tend to have very weak, very dilated hearts. I also want to draw your attention to this racial demographic breakdown. The percentage of Black and Indigenous patients in CHFP is disproportionately large compared to Seattle and King County. And this just reflects back on that statement from the Heart Failure Society of America and the AHA that these are communities that are getting less access to healthcare. About 70.8% of our patients have presumed methamphetamine-associated cardiomyopathy. Presumed is a key word because not everybody has had an ischemic evaluation. It can be very difficult to get patients in for ischemic evaluations if they don't get one in the hospital. So sometimes we are left to presume, but it is important to indicate when they have not had a full evaluation. Also, 31.6% of our patients are diagnosed with a severe mental illness. Those illnesses are listed below. But I really want to point out that underdiagnosis is extraordinarily common due to lack of PCP or mental health care. And also that if there's a comorbid substance use disorder, often mental illness symptoms are attributed to substance use. So this is almost certainly an underestimate.
This graph shows where our patients are living. I think it's really striking to see that 35% of our patients are actually currently homeless right now. 45% live in permanent supportive housing, which means that they were homeless at some point. Permanent supportive housing, for folks who don't know, are a lower barrier housing option for people who have been homeless. There are services there such as case management, counseling. Sometimes there's a nurse and an MD in the building. Of note, only 3 of our patients are in private homes.
So after looking at some of our current demographics, I want to step back and talk a little bit about how we started this program pilot. Patients being readmitted for heart failure or being frequent flyers, as they're often called, is a known issue that I suspect everybody in this room has probably dealt with. From our own work in cardiology, we knew that it was a major issue at Harborview. So when it came to creating this program, this was an issue we knew we wanted to address, and we knew we needed to understand what population we needed to reach and what their needs were. So we reviewed, this is back in 2020, so the data is quite old now, but we reviewed heart failure readmission data from Harborview for 2 years and saw the people that were being readmitted were primarily young, male, Black, or Latinx, had CKD or experiencing homelessness, substance use disorders, and mental illness, which you will notice are things that we are focusing on in our program. We also had a lot of conversations with key stakeholders. I think this is really important, and this sometimes gets left out of program development. Our cardiology attendings who have worked at Harborview, they have a great understanding of what is and isn't working, what patients are they seeing in the hospital, and then they're not making it to clinic. And the most important group we were talking to were the patients who weren't making it to clinic. So we would spend a lot of time in the hospital talking to them and trying to understand what their barriers to care were. And it's also helpful to see the people who are overcoming those barriers and are making it to clinic. What is a protective factor for them? What's helping them get there? And from these conversations, we've identified a few major issues. The first is pretty simple. It's just too difficult to get to clinic. There's competing survival priorities. So the times don't work with people's work schedules. They need to find food. They need to stay well. So they need to deal with their substance use disorder. They need to find shelter. They just don't want to come to the hospital. They've had really bad experiences, and they really only think the hospital is a place to go to in extremis, not a place to go to get regular care, get well. They don't trust the medical system, or they don't understand that their condition's chronic. From these issues, we identified 3 major needs for both our target population and also for our organization. So these are what we were trying to address with our program. And one is, of course, access barriers, quality of life improvement. Many people were talking about how poor their quality of life was, and then address these inequities in care that patients were clearly seeing. And then, of course, we need to make this a viable thing for our organization. So this is not going to be a high earning program. So our goal is to, make money by reducing costs, essentially, reducing readmissions and ER visits and shorter length of stay, which allows us to open beds for more patients. And of course, we want to align with our organizational goals, as Harborview has a mission to serve the most vulnerable residents of King County. So what we know is that these are not unique issues and that there's many innovative ways to address them. There are a number of field-based programs throughout the country that provide care where patients want to receive it, but they tend to focus on acute needs like wound care or primary care. And on the other hand, there are some extremely innovative low-barrier heart failure clinics for underserved communities, particularly the HRSA clinic out of the University of Alabama and the heart failure clinic at the Sharp Chula Vista Medical Center down on the US-Mexico border. And these are really excellent low-barrier programs, but what we found is that there wasn't really any kind of long-term program that combined these two things. And so that's what we set out to create. This was our answer. This is our backpack. This is our clinic. This is what we carry on our backs. And this is how we see our patients.
Although we started seeing 1 or 2 patients in 2020, it was not until October of 2021 that we started working on a pilot project. Between October of 2021 and March of 2022, we enrolled 16 patients. And during this 6-month period, Jaimie and I would take half a day and we would walk to go see the patients. They needed to be around Harborview. The inclusion criteria at the time was less stringent than it is now. Patients were flagged by inpatient teams at Harborview, and Jaimie and I would meet the patient at the bedside and come up with a plan on where to meet them. We would help inpatient teams when the patients got readmitted and come up with discharge plans and maybe help with situational awareness. This is a photo of a dumpster. One of our patients lived behind it on that blue tarp. We saw her a couple times there, and she's now housed, we're happy to say.
So we were able to look at the results of our small pilot, and they were very promising. We looked at 6-month pre-enrollment versus post-enrollment data because the admission was a rolling admission. And we found a 36% reduction in all-cause readmissions and a 58% reduction in patients with more than 1 hospital stay, which is actually to say that over half our patients did not get readmitted again after they joined the program. And the average length of stay increased from 4 days to 2 days. But a really cool and interesting thing was that there was a significant increase in outpatient appointment attendance. So not just us, but we were starting to be able to get them to trust and go to other care providers and services as well.
So based on these outcomes of the pilot and the support of UW Cardiology, we received approval from the hospital administration at Harborview to create a full-time 5-day-a-week program in October of 2023.
And this picture here is at a shelter. This is one of the patients that we see. This fancy thing up there is one of our alarmed medisets. We fill them for 28 days and then we lock them, and it rotates on its own every 24 hours and it makes a sound like a fire alarm and flashes until you pick it up and flip it over and take the pills. And our patients love this. It's a huge help in remembering to take their medications. You can also see that there's a lot of rotting food. This is the only food the patient had. And there is a hoard consistent with methamphetamine use disorder. So we expanded our service area once we became a full-time program because we got access to a U-card, and we really began refining our criteria. We distilled our referral criteria into its current iteration. We wanted to prevent selection bias, so we didn't want people to get in just because somebody knew us. And we wanted to fairly deal with the fact that we kind of got caught in an onslaught of referrals immediately when we started. So we wanted to kind of deal with those as fairly as we could. And then we knew we needed to expand. So we focused on adding team members that could address the biggest needs of our program, namely, of course, a cardiologist, especially one like Dr. Yadava, who has a lot of imaging experience and could bring more services to our patients and also help us with our research as well. And then we've also recently added Dr. Hidano, who has brought even more expertise to the program. The other big thing we needed was a pharmacist because we had this rapidly growing medication management program where we're intensely managing medicines for patients. And so we really needed a pharmacist to manage that. This is an RV where we saw the patient. That tarp over the top is because it leaks, and that floor was very wet and mushy. And there was a lot of mold and mildew, and he had asthma, and it was a really, really tough situation. And he is actually now living in a car, and he's a little bit transient, but we're still able to see him.
One of the first things we did when we went full-time was write a mission statement. During our pilot, we understood that this work was going to be super complicated for us, and therefore a mission statement would help us do our work. I can let you read the mission statement, but essentially we just see patients where they want care. We accept patients who've not been able to engage in the traditional outpatient setting, and we provide a non-judgmental approach to their heart failure care.
And it was important to us to also create a care model that would provide templates for programs like this. And it needed to be something that was flexible enough to adapt to other institutions and states, and also potentially other conditions, while also providing a consistent standard of care. So this is the Community Heart Failure Program model. It's a published model, and it's a trauma-informed model based on the dual core concepts of advocacy and personalized heart failure care. We're going to talk a little bit more about each of these parts.
We're going to start with the trauma-informed care principle. This is the center of our model. When we did our pilot program, we understood that using a trauma-informed care approach when meeting a fragile heart failure patient was going to be very imperative. The definition is on the screen. However, it's the lens by which we engage our patients. Remember, we're seeing patients who've been failing the traditional medical system. They often have been banned for clinics. They have care plans when they come into the hospital, and when admitted, they usually don't stay until they're ready to go. So using a trauma-informed care approach has helped us engage a patient. Instead of asking, "What's wrong with you?" we have learned to ask, "What happened to you?" And this concept really helps us engage a patient, and it's really the core of our work.
So I'm just going to talk a little bit about the two-concept model here. The first part is advocacy. Of course, it's a really core part of our work. We see it a little bit like being ambassador between these two cities. Because of the intimacy and the nature of our work, we've been given a really different context than most healthcare providers have. And we know and understand some of their barriers and social determinants of health better than you can if you're only seeing people in a clinic or a hospital. And we can relay and provide this context and help explain it to other healthcare providers and provide recommendations to make care more accessible. It also goes the other way. We often see people in areas like 3rd and Pine and 12th and Jackson, these local hotspots, and people are very suspicious at first. It's like, what are you doing here, and why are you coming around? And then they see that you're providing care for their friends that they know are really sick. And we begin to gain the trust of communities, and through that, we find that we can help them seek healthcare. We also help a lot with what should be considered simple navigation. This is like decidedly analog in a very technological world. Most of our patients can't access telemed. They don't have reliable phone numbers. They certainly couldn't wait on hold for an appointment. And so a lot of it is figuring out, okay, how are we going to get them to this procedure? How are we going to schedule it? Leaving notes, talking with case managers and other people in their community to try to find them, and really relying on kind of old-fashioned techniques to find and connect with people. The other one is my personal favorite. This is my favorite thing to talk about in the whole wide world. Personalized heart failure care. This is where evidence-based practice meets trauma-informed care, or if you want to think of it like heart failure guidelines or meeting a person's reality. At the very basis of this, because I think it's a really good place to start, is really starting to recognize the social determinant of health limitations. We're going to show you a picture in the next slide of somebody's food that they have for about a week and a half to get them through a week and a half. Food insecurity is so real in this area, and a lot of times the food that people have access to is very high in sodium, or they really have no control over the food they have access to at all. So focusing on things like sodium reduction in their diet, or tailoring a diuretic regimen to a perfect low sodium diet in the hospital, it isn't realistic, and it can be really demoralizing for a patient. They either think, well, I can't do this, so I'll give up, or in some really scary situations we've had, they've just stopped eating. And so it's being really aware of things like this, and also transportation issues and work schedules, trying to schedule procedures in the hospital, maybe, even though that's not a normal standard of care if we know they're never going to make an ischemic evaluation outpatient. This other one, which was really humbling for me, is explanation of disease processes. I thought I was so good at explaining things really simply and creatively to patients. And when you get into their home and kind of the power balances change, one of the first things that people would often say to us is, I have no idea what's going on. They just didn't really want to look dumb in the hospital. And so it's taking it all the way back. Like a lot of people, even though they've seen those diagrams of a 4-chamber heart, they can't relate that to what's inside their own body. And more importantly, they can't relate how these symptoms connect to their heart, why their shortness of breath or their leg swelling or their fatigue has anything to do with their heart. I mean, we all know that naturally, but they don't really see that there's a connection. If something's wrong with my heart should hurt. And so it's becoming really, really simple and going back to the very basics, with less of a focus on pathophysiology and more of a focus on how does this affect the person. And then the other one is understanding individual goals. Many of our patients, having a recovered EF or getting advanced therapies, these might not be their goals. They may not want to get clean. They might just want to breathe better. Hernia surgery is like the #1 reason people tell us that they want to make their heart better. Like they want to get a hernia repaired. And so that becomes our goal. All right, fine. You want to get your hernia repaired? Let's get you stable enough to get your hernia repaired. And in the process of that, we can begin to address some of these other goals as well. And I think the biggest and the most important thing is adapting medication regimens. I was also reading in the Heart Failure Society of America's Epidemiology and Outcome report that only 36% of patients are on ARNPs. And I really chuckled because I think I'm the world's biggest deprescriber of ARNPs. Going into a patient's home, one of the things I always see is that they've had really well-intentioned people trying to put them on optimal quadruple therapy, and they're not taking it. They can't take the twice-a-day medicines, or they realized they couldn't take twice-a-day medicines, so they took everything at once, and then they felt awful, and so they stopped taking everything. And our earnestness to make sure that we have all patients on the best medicines, the best preventative medications, sometimes that makes it too much. And then we've gone completely backwards because now they're not taking their medications at all. So lots of times it's starting over and starting very simple. Once-a-day medicines, a single pill, building pills slowly, and even not giving medications that we know are beneficial, like a statin or something, because it's like, okay, what is the most essential things to get in your body on a regular basis? The other thing is we really need to be more aware of cultural suspicion around pills and experimenting. This is a huge issue in the community that I've heard a lot about recently, especially from people who grew up in the rural South. Many of them had experiences with their parents or other family members where they never had access to healthcare. And then they came into the hospital when they were older and very sick, and they left with a lot of very expensive pills, and then they died. And so in their connection, pills equal death. And a lot of people don't want to take medicine for that reason. They kind of see it as an experiment. So trying to be really cautious with how quickly and how aggressively we're adding medications.
As part of our care model, we have 4 components to a visit. So trust, obviously, this is always step 1, and not much happens if we don't build it. So we really start there. The harm reduction model also is another component. Out of the 158 patients that we've helped, only 16 have not had a substance use disorder. So it's essential we use harm reduction approach and make sobriety not a condition to our care. Harm reduction can be controversial, but it's also about choosing to work to minimize the harmful effects of drug use rather than simply ignore it or condemn the drug use altogether. We also use harm reduction when navigating heart failure care. This might look like reducing pill burden by removing a beneficial medicine like a statin in order to help a patient take their medications more regularly. Care coordination is another important component of our care. As a team, we work really hard at making strong relationships with case managers, building staff, front desk staff, family members, everybody. And we also do a lot of coordination with the healthcare system, as Jaimie mentioned. That can look like talking to the cardiologists and the cath lab staff when somebody's got a severe anxiety disorder, or introducing the patient to a new primary care provider that can help them with other issues. Finally, we use shared decision-making. I think you can hear it in our slides. We find that allowing patients to drive some of the decisions in their healthcare really helps with better outcomes. So this is a picture of a patient. A lot of people run out of money by the middle of the month if they're getting money from the state or federal government. and this is all they had for the rest of the month. But we were very happy to see that his heart failure meds were there. Yeah.
The 3 cans of food he had to last him a week.
Yeah, that's very common.
So just a little bit about the outcomes. For fiscal year 2024, we looked at an N of 80 because we were looking at people who we had at least 6 months of data on. And among these people, there was a 27% reduction in all-cause ER visits. So not just for heart failure, for any reason. And then all-cause readmissions decreased by 57%. So again, that's not just heart failure, that's any reason to come into the hospital. Average length of stay decreased by 37%, and there was about a $3,000 decrease per patient in direct costs, which doesn't seem that exciting, except that there's pretty well published but conservative estimates that there's an 8% increase in total costs per year of heart failure patients, since they tend to need more care over time as disease progresses. So it's not only, our goal maybe was to slow that trend, but to be able to actually turn it the other way, especially for people with such severe heart failure, is a pretty big success for us. We also, between the saved admissions and this reduced length of stay, saved a lot of bed days. Bed days used decreased from 510 to 155. And if any of us remember the days, when we're really over capacity, that kind of stuff matters. That means more people get care. So between all these things, again, not a big moneymaker, but these cost savings are enough to pay for the program and avoid, of course, patient suffering and keep beds and resources available for other patients. We want more outcomes. It's great to know that things are working out well for the hospital, but we really want to know how things are working out well for our patients. So we've been trying to get some funding to do patient-reported outcomes research, to actually hear from our patients what they think is working in the program. Dr. Yadava has also started our very big, daunting project of our REDCap database. We're trying to look at long-term outcomes in a number of different areas: EF, medication adherence, GDMT adherence, admissions, readmissions, comorbid disease management, outpatient engagement, and mortality. And we really want to be able to capture this at 1, 5, 10 years. What is the long-term impact of this kind of a program? And that just takes time. The other thing we're so excited about is we're all part of the UW methamphetamine-associated cardiomyopathy work group, which has some really exciting stuff going on. Dr. Sarah Leidy, an addiction medicine specialist, is doing a qualitative study of people with MACM and their experience in the healthcare system. And our own Dr. Hidano is starting a genetics project looking at the prevalence of genetic variants in patients that have historically been labeled with MACM to support a 2-hit hypothesis. Our patients are so excited to take part in this stuff. It's really surprising to us. And, a lot of the people that we see are not represented in research and not represented in the big studies that we see. So getting them involved and having them be a part of the process is another way to improve inclusion and equity. So of course, we're still in the process of building our database and tracking long-term outcomes, but we do have a couple of case series that we've presented. This most recent one was presented at ASE a few weeks ago. It's well supported in the literature that cessation of methamphetamine is strongly correlated with improvement in LV size and function in MACM. But an interesting trend that we have begun to notice is that many of our MACM patients are seeing improvement in their LV size and function with just good adherence to once-daily GDMT. They're actually not stopping meth use. And this is important because meth is really hard to stop. It's the hardest drug to stop. There's no good medication-assisted therapies. The only really good strategy that's out there is contingency management, and that's very hard to access. So in the setting of they may not be in a spot to be able to quit, if they can reduce their use and take their GDMT and still experience these kind of improvements, that's very promising. We're going to end with a case study. We love this case study. We love this guy. This is a 56-year-old Black man with non-ischemic cardiomyopathy, chronic HFrEF, and LV thrombus, a CVA he had in 1994 with residual right-sided hemiparesis. He's in a wheelchair. He has COPD. He's had multiple PEs. He has a very large right inguinal hernia, and he has polysubstance use disorder, primarily cocaine, which he's used since he was a young teenager, but also methamphetamine as well. When we first started seeing him out in the community in November, December of 2023, he'd just gotten out of the hospital, which he'd left AMA. And during that hospitalization, they did an echo, and his LV EDVI was 202 milliliters per meter squared. His EF was 17%. He had global LV hypokinesis, impaired relaxation, and elevated filling pressures. And this was not acute heart failure. His LV had been severely dilated, and his EF had been less than 30% since he was diagnosed in 2018. And he'd been in the hospital a lot, so we had great serial echoes on this guy. His heart had never gotten better. He also had a behavior alert, a big care plan that popped up when you saw him because he had repeatedly severely assaulted several staff members. In fact, in almost every single admission, there had been a staff assault, including the most recent one when he actually knocked the molar out of a PCT who was trying to help him stand. He had attended 2 cardiology appointments since his diagnosis in 2018, none in the last 2 years. He'd never filled an outpatient prescription, and he either couch surfed or lived in his wheelchair on the street on the corner of 3rd and Pine. In the 2 years prior to seeing us, he'd had 146 ER visits, 108 of which were at UW hospitals, and 27 hospital admissions, 20 of which were at UW hospitals, at least 10 of which were ICU admissions, and almost all of which he'd left AMA.
When we first came to see this patient at his shelter on Aurora Avenue that December, this is what he looked like. And I might add, this is not an unusual situation for us to find our patients when we first start working with them. He was dysmic at rest. He had anasarca, unable to push himself across the room to the restroom, so he urinated in his chair. He was sleeping upright in his wheelchair with P&D. Blood pressure was 90/70, heart rate in the 130s. We were unable to get an oxygen saturation on him. He had cool extremities. He refused physical exams. He refused to take his medicines. No blood draws, wouldn't allow that, and he would not go back to the hospital. He explained he'd been repeatedly discriminated against in multiple area hospitals. He felt judged for his drug use and homelessness, and especially for being deemed violent when angry because he was a Black man. He felt he was dismissed or deemed incompetent because we had difficulty understanding him due to his stroke. He recalled experiences of being restrained to beds, not allowed to leave or make his own medical decisions. I had to fight for my life in there. So what did we do? Took a deep breath, that's for sure. First, we had to build trust, and we really needed to use our trauma-informed care approach with this patient specifically. So we just came every Wednesday morning to see this patient at his shelter. We bring him some food, and we just checked in on him. Just say hi, how you doing? And we focused on his priorities. He wanted some food, didn't have much. He wanted to reduce the swelling in his legs and at his hernia site, and he wanted to breathe easier. And despite not feeling great, he really refused to go to the hospital. So we used harm reduction as a lens. This patient had been using cocaine since he was a teenager, so we weren't going to talk about abstinence. Instead, we supported his decision to reduce cocaine use, which was multiple times a day, to maybe every other day or every 3rd day. We did a lot of shared decision-making, especially with medication management. We asked him what symptoms bothered him the most, which was his shortness of breath and his swelling at that hernia site. So we gave him a diuretic and an inhaler, and he used it PRN. When he saw that actually helped and he could trust those medicines, we started to add some GDMT, and it took months for us to get him stable. However, he now takes his medications every day and is on full GDMT therapy. This is his little alarmed Mediset in his sweet little apartment up by Harborview. You can see he's got his crack pipe there and he still smokes, but it's really social now. It's not like it used to be, his drug use. Finally, we did a lot of care coordination. We helped the shelter staff initially really build a relationship with the patient. He was so difficult that we feared that he would leave the shelter or get kicked out. So we really worked on that piece. And then we asked our colleagues with the homeless palliative care team to help us with primary care issues. And as he became more stable, we finally were able to get him into the surgery clinic, which he had been banned from. And he was able to get his hernia repaired last summer. So let's just quickly look at those numbers. 2 years prior to meeting us and then the 2 years after with us, those 146 ER visits went down to 12. 5 were for postoperative pain after the hernia repair, 3 for complications from an assault, 4 for COPD, none for heart failure. In the 2 years before engaging with this patient, he had 27 hospital admissions, and after engaging with us, he had 1 admission, and that was just very close to when we met him, and he did leave AMA from there, and it was from the ICU. In 2025, he had no ER visits and no admissions. He's attended over 100 outpatient visits, including PT, OT. He goes to his primary care. And he's had his care plan deactivated. That took a lot of work on our part. And he no longer needs surgery or security to escort him onto campus. As mentioned, he also got that hernia repaired.
One of the coolest things, though, has been to see the improvement in his cardiac function. If you look at that parasternal long access view from November of 2023, his EF is 17%. His LVEDVI is 202, as I'd mentioned. His LV internal diameter and diastole is 7.47 centimeters. And this is him in July of this year. His EF is 61%, his LVEDVI is 69, and his LV internal diameter and diastole is 4.5 centimeters. And again, I really want to stress that the first echo is not acute heart failure. His heart had looked like this for quite a while. This was not a new finding in November. And then this is just kind of another visual function in a 4-chamber and 2-chamber apical view of the changes that we were seeing in his function. And the really interesting thing here is this is the GDMT he's on. This is what he was taking, is taking. And he never wanted to go to BID medications. This was about his maximally tolerated doses. And while we'd had him on some of this medicine for a while, we didn't actually have him on this full regimen for more than 3 months before this echo. Another thing that's pretty interesting is that improvement in his EF actually motivated him to reduce his use further and to reconnect with his family. He expressed that now that he doesn't feel like he's going to die any day, he has to think about his future. So now he's actually gone from I would never accept a preventative medicine like a statin to I really want that medicine. And he's excited to go see his family for Thanksgiving this year. He was last seen on September 30th, and he had not used cocaine in over 3 weeks. He'd also gotten his friends to start using fentanyl test strips to prevent accidental overdose from cross-contamination, which is very common with crack cocaine use. And I think this is a good example of something that seems tedious and hard and maybe a little bit hopeless. And I know in the beginning when we were showing up with breakfast, we really wondered what we were doing with our time sometimes. But it's a really good example that building these relationships and adapting care in this way can create outcomes that are beneficial to the patient and the system and can dramatically outweigh the costs of our time and visits. So looking forward, we always want to keep growing and adding things. Our approach to something when we can't get it for a patient is how can we do this instead of we can't do this. That was a lot of the thought, I think, behind Dr. Yadava and building up our point of care echo program, which has been a huge help. We're also building the plane while we're flying it. You know, we're using new technology for our EKGs. For years, we've been trying to get this point of chemistry and IV diuretic system up and running, but we've had a lot of setbacks with state licensing delaying implementation, which is something we knew nothing about and we've had to learn a lot about. And hopefully it really will start December 1st. And then the other major thing has been program growth. I think when we started this, we didn't know if anybody would actually be interested in this work and if people would refer their patients, but that's not been the case. And we actually had to close our referrals outside of Harborview in February of 2025 because we were at the capacity of the number of patients we could safely see. We planned then to add more staff, but of course there was a major financial crisis that's impacted all of us and it became very difficult to get additional FTEs. However, we have recently gotten an additional nurse FTE and we have some really amazing cardiac providers in our clinic who are interested in joining us. And then our next step will be how do we best increase capacity to improve access in a way that's fair and equitable. I think it's reasonable to think, okay, this is a pretty niche population. How does this apply to me? First, I think there's a lot more poverty and inequity than we think, affecting more people than we think. And the purpose of this model is try to create something that can be done with other populations. Homebound older adults is probably the biggest group that we have to turn away in terms of referrals. Rural communities, and then other chronic illnesses. We co-manage so much diabetes and COPD because they're just not getting care. And in a value-based care system, this is even something that could be used as part of early screening and prevention. This program is a good example of value-based care when it's working. I mean, this is focusing on the outcomes, not the fee-for-service. These are not, again, you don't bill very high for these things. But if you're looking at an outcomes-based care as opposed for a fee-for-service model, this then does become a pretty financially viable program. So it's just kind of another plug for that model of care. And then our last thing, just to wrap it up, is our lessons learned. How are we supposed to help these people? This is a comment we often hear, usually with a significant degree of very well-earned frustration. For us, it's become a little bit of a mantra and a challenge. Like, how do we reach people that have been deemed unreachable? And really at the core of this, what we've found is that nobody wants to die drowning in their own lungs. Heart failure untreated is a terrible way to die. People really do want to feel better and they do want help, but because of multitude of system barriers, they don't necessarily see the healthcare system or healthcare providers as a source of help that truly understands their needs. But that's also not hopeless. We absolutely can become that source of help by trying to understand the context of the patient and finding creative ways around the barriers. For us, that might mean going out to people, but for others, it could just mean things as simple as adjusting the way we give GDMT or the way we talk about sodium restriction.
We've also learned that building something new, if it's a relationship with a patient or a program like this, it just takes a lot of time. Finally, one of the lessons we've learned and we believe in dearly is that as a center of excellence, the University of Washington can provide the most advanced treatments at the same time as helping the most vulnerable. We hope our presentation has illustrated this. And this is another place that we've been seeing a patient. Unfortunately, the city's been sweeping this area a lot. So we've now lost touch with the patient.
We just really want to end by acknowledging a ton of people who've made this kind of work possible. I think the biggest person we really need to thank is Pat Laura. Having a service line director that deeply believes in this work has been essential to making it successful. And of course, Dr. Yadava and Dr. Hidano, who have done massive things for our program, as well as our pharmacist, Alex Deng, and UW and Harborview Cardiology leadership and our research partners, as well as our Harborview administrative staff. And then I just have to send a special shout out to Elliot Balo, my husband, who's been kind enough to keep our family together while I built a program with 2 toddlers and is also an awesome APP on CARDS-B.
And then Jaimie and I and our whole team wanted to highlight and thank our patients. It's through their resilience and their grit that we've been able to provide this kind of care, and we're grateful to them for trusting us. Thank you, and we'll take questions.
One thing we also want to say is if anybody wants to come out and see the work we do, we are happy to bring people with us. It can be really beneficial to see this work and to see what people's lives can be like. So there's our contact info if you guys ever want to come join us.
Thank you, Kate and Jaimie. What a fantastic presentation. I don't know about the rest of you, but I could feel the hair on the back of my neck stand up in between. That was very moving. We'll open this up to questions. There's just one comment on the chat here by Marshall Corson, who says, "Congratulations on this awesome work, Jaimie and Kate. Your achievements truly embody the goals and mission of Harborview and should be an inspiration to all of us in delivering humane, non-judgmental care." That was Marshall Corson. And if there's any questions.
I'll ask one. I guess, hi, Marshall. Great to see you online. But just a question. So I was surprised to see that there's not a mental health provider or addiction medicine on the team. I mean, I'm sure you guys are quite capable of navigating, but I mean, we have experts at Harborview. Can you comment on, are you guys working on bringing those folks on board? Because I think their experience will be very valuable to the patients.
Absolutely. So we do have an incredible addiction medicine program at UW, and we work very closely with them. We will try to connect our patients, even go so far as driving them to the clinic. And a really cool thing that we've actually started in conjunction with the addiction medicine program is there are addiction medicine fellows that come out with us on Tuesdays now to see patients that we are not able to get into clinic. And in terms of mental health providers, I mean, I think that's probably our greatest wish, that we could hire a mental health provider and have them be a part of our care. I mean, it would be life-changing. For now, it's just trying to connect them with the services that are available, which admittedly are not great for people that are low income, and the wait lists can be long and it can be difficult if someone's kind of in an acute crisis, but it's an area to work on for sure.
I mean, that was just a fantastic talk and a amazing window into this world that we sort of see glimpses of, and you guys spend so much time in. So thank you. I wanted to ask a GDMT question. I was struck by the improvement at relatively low doses, and I'm curious what your experience has been with the kinds of GDMT that these methamphetamine cardiomyopathy patients respond to. You've both spent years taking care of lots of different kinds of cardiomyopathies. Do you see a difference in response in this particular patient population? And we spend a lot of time trying to push up doses, but it's a huge gap in our evidence base about like what doses really work. We actually don't know that much about it. And so I'm curious if you've had experience about, what dose thresholds you start to see people turn around.
Oh, yes. Yeah, this is something I'm very excited about. We're tracking in our REDCap database. Yeah, so methamphetamine-associated cardiomyopathy tends to respond to low-dose GDMT very well. Most of those people in that 7-case series were on, doses of losartan that were 25, 12.5, 37.5, 7.5, 5 of losartan. But a key is for most of them, we can get them on quadruple therapy, even if it's doses that are so tiny, they might be considered homeopathic. And then the other biggest thing, like more than even the dose or the type of medicine, is consistency. Being able to go into somebody's home and count pills, you really start to understand consistency. And that I think a lot of people overestimate how frequently they take their medicines. When you have a lot of ability to help with things like medication adherence, that's really when we see the biggest change, is when they're taking them every day, even at very low doses. I would say in our experience, methamphetamine-associated cardiomyopathy does tend to respond better than other kinds of cardiomyopathy to low-dose GDMT.
I have a question. So first, thank you so much for that talk. Absolutely phenomenal. I'm sure this has been life-changing for so many patients in your care. So this kind of brought me back to when I was in residency. One of my pivotal, experiences in my training was that I was part of a internal medicine, like transitional care clinic that served the underserved in Chicago, probably a very similar patient population to what you have. And, the clinic was kind of led by this physician who is an absolute saint. And I think that's something that she kind of ingrained in me is, as you mentioned, meeting patients where they are. And so we didn't go out into the community. We had like a clinic that patients would have to come into, but something she addressed was, sometimes we wouldn't even talk about patients' health conditions. We just give them a bag of groceries, or, we try to give them a coat or a pair of shoes just to get them through the winter in Chicago. And so I was hoping if you guys just could comment on ways that this program, either in and of itself or via partnerships with other programs, is addressing the other adverse social determinants of health that we find are barriers oftentimes for these patients.
Yeah, that sounds like an awesome place. I think showing up at somebody's tent or shelter bed says like a huge amount. It shows us that we're willing to take the time to come and actually meet the person. So I do feel like a lot of the power of this work is actually coming to the person. And we've lost that bit in medicine. We assume that everybody's just going to come to these extraordinary medical centers, and get great, awesome care. But for our population, us just showing up as a person and saying like, how can we help? We heard you were really sick. With the other pieces, we're very lucky. We've gotten a lot of donations from private funders. So we provide a lot of food, insurers, clothing, simple things, underwear. It just makes, whatever. We all know this is really hard work. It's really hard and sad what little our patients have. So yeah, those little simple things. And then not going in, they know they're sick. Like, you don't need to be brain surgeon to figure that out. So a lot of times we just won't even talk about it and just try to build a relationship first. And then just admit that, just ask them, like, just say, you must be really scared. So yeah, it's scary. It's hard.
In our case study, that gentleman, we bought him McDonald's pancakes and orange juice like every week for probably 2 months before he started taking a diuretic. That was literally the therapeutic intervention, but it worked.
Thank you so much for that talk. That was incredible. One thing I wanted to learn more about was the IV diuretic rollout, and it sounds like that's kind of the next big thing you're working on, and whether, it's more like a state barrier or there are other programs in the US that have done something similar. and kind of like what you envision in terms of how like being able to provide IV diuresis and PO point of care chemistry would like change your scope of practice.
Yeah, this has been a big learning experience for us. So we actually had, oh my gosh, 3 years ago when we started thinking about this, come up with a whole IV diuretic protocol based on the literature that's out there. Because yes, there are definitely other places that give IV diuretics at home. Not so much in this setting, probably more stable settings. But the point of care chemistry was the really big learning curve for us. There's a ton of state regulations around it and a lot of state barriers. We all had to have our high school diplomas and send them into the state before we could use them, even though, I mean, it's like a bunch of doctors and nurse practitioners, like we all have a high school diploma, but I mean, do you know how long it took us to all find our high school? Yeah, yes. And they wouldn't accept another. So I mean, do you know how long it took a bunch of us to all find our high school diplomas and turn them in? And then, it has to be calibrated, and then there's a line for IT and you're at the back of the line. So it's a lot of institutional and state barriers. We've worked through them and we actually have the machine. And then I think once we get the final approval, then we'll go back to our IV diuretic protocol that's now very old and make sure that we are approaching it with the most up-to-date information. We're hoping for a December 2025 rollout.
I think also the cool part is just being able, if somebody's super sick in front of you and they will not come into the hospital, to be able to get an idea about where their chemistry's sitting so that we can change the GDMT because we may not find them. So we're really excited about that piece too. Yeah. They'll be the first one at Harborview. Can you imagine? Like they don't need an iStat because they've got such great labs, but we're going to be the first.
I'm just curious, because you spoke about how low dose this is a knowledge gap for me. Are there any compounded medications that combine aspects of the GDMT that could maybe reduce the pill burden 4 pills a day, 3 pills a day, 2 pills a day? Is there any research going on that? Is pharmacy or pharmaceutical company possibly interested in that?
That's a good question. Our pharmacist, Alex Sting, has talked a lot about this. There are combination medicines more for hypertension, not so much for heart failure. And there are other barriers as well. We have to titrate our medications on our patients often very slowly. I mean, Kate gets irritated with how many half pills we have to cut because I'm like, we're going to go up 2.5 milligrams at a time. So if it was going to be helpful, it would have to be some of these patients who are in very stable doses. And I mean, you can see the gentleman we showed, I mean, that's an odd regimen, like 7.5 of lisinopril. So I think there's utilization for it in heart failure. I don't know how useful it might be in this population. I also think when it comes out, it will probably be cost prohibitive for a lot of our patients.
Awesome. In the interest of time, we'll probably call it there. But I just wanted to tell you guys that you're getting a lot of kudos on the chat. And if I could just take just 10 seconds to bring up a couple of points on the chat that I think, if anything, we can think more about as we go back. One is there's a lot of questions about how this can be replicated locally and nationally, and we have thoughts on that. Babak brought up the emerging role of GLP-1 agonist medicines in addiction. I'll be honest to admit I know of it in opioid and alcohol. For meth, I'm not aware, but that's an excellent point. The combo pill point that Chen brought up is interesting. Fareed just told me compounding pharmacies can help us with that. So that's a thought I've had for a while. In underdeveloped, low socioeconomic strata countries, that's a strategy that has worked. So lots of interesting thoughts. But on that note, thank you. Thank you for that fantastic presentation.